We're very fortunate to have Dr. Brien Smith of Spectrum Health and Dr. Seth DeVries of Helen DeVos Children's Hospital here. I was going to really introduce you, Brien. Dr. Smith is a man who needs no introduction. Many of you may know, besides being head of neurology at Spectrum, he was recently mentioned on CNN because, and I think I can say this because HIPAA doesn't apply, because Coach Kill from Minnesota, has been under treatment by Dr. Smith, and he's been given real kudos to him for helping him out right now, and which is why he's back coaching with Minnesota. Those of us who are U of M or MSU fans would probably prefer that he was either here or not, you know, but the fact is this is a man who came forward with his epilepsy and has really sent a message to many, many people. Dr. Smith is also the immediate past chair of the Epilepsy Foundation and is also been involved with the Epilepsy Foundation for many years. Dr. DeVries is a pediatric epileptologist, and he's the newest member of the Spectrum Helen DeVos team. He completed his fellowship at the University of Michigan, and without any more, I'm going to just hand it over to Dr. Smith and Dr. DeVries. Thank you.
Thank you. Thank you. Am I on? Can you hear me? Yeah? You hear me? Just a couple housekeeping things before we open it up. The first one is if you could wait when they bring the microphone to you, because there's a tendency to start your question. We can't hear half of it. We want to be sure the audience is able to hear that full question before we respond. And one other thing I'll mention, and this was kind of similar to the disclaimer I made last year, remember the responses you get from us is an opinion. And that opinion may differ from other opinions you've heard, or let's say you ask a question about yourself or a family member and you're thinking, wow, my doctor's doing this. That doesn't mean your doctor's wrong. It doesn't mean we're right or we're wrong. There are lots of different options out there. There are going to be different opinions based on experience or luck in some cases. Remember, there's almost 30 seizure medications, and if you look at the clinical trials to prove which one works best, guess what? Short of a few exceptions for certain seizure types or syndromes, there's really no magic bullet out there. And every day in clinic, when we talk to patients and say, well, we could use this, or this, we really have no way to predict which one's going to be that perfect medication that actually works. And unfortunately, that leads to trial and errors that it may take 6 to 9 months before you actually find that pill. So I just want to, again, put out that disclaimer because the response you hear may be different than what you've been told in other discussions. It doesn't mean one is right or one is wrong. It's a response to your question. So thank you for understanding that. And Dr. DeVries, do you have anything else you want to add before we open up the floor?
I think we're really excited to answer any and all of the questions that come up.
Very good.
Yeah.
Well, while you think of the questions, I'm going to just give a little commentary on a couple of the things that came out in the previous 2 talks. And Phil and Patty did a great job. I mean, Patty's overview of the Pipeline Conference was amazing because there are so many moving pieces and things that are happening. Just to give you a little perspective, because we tend to talk about new drugs and new technology, and I'll comment on both, having some experience with both of them that have been approved. So Visualase, remember, is that the procedure where you're using a small catheter and you're going through a little burr hole in the skull to feed that catheter down to a deeper lesion. Now, you shouldn't think that, wow, there's this new thing that it's available for everyone, because right now it's got a very limited indication in the sense that if I have a patient who has epilepsy from some type of tumor or abnormal anatomical tissue, sometimes we call it heterotopia or dysplasia, that's in a deeper part of the brain that usually is not very accessible by typical surgery, that's where Visualase comes in, because what you can do is, under MRI guidance in an operating room, after making that burr hole, you thread the catheter down to that deeper region, and that catheter kind of melts the lesion. It's thermally treated, kind of heated, and goes away. Now, so there's a limited indication right now, and when I say indication, that's how it's being used. There's not been any comparative trial comparing visual ACE to standard epilepsy surgery that says, wow, yeah, visual ACE is the way to go and there's no questions asked. That trial has not occurred. So right now, if you read the literature on what it's being used, it's in selected cases that have a deeper seated lesion. So the numbers are not very big because of those limitations currently. The other, and you're going to get a talk a little bit later on epilepsy surgery, NeuroPace, which is the stimulation device which actually stimulates directly into a portion of the brain through implanted electrodes, and you have a computer generator implanted in the skull. That was a device that went through significant clinical trials over a 5 to 6 year period, starting just after 2003, I want to say. I can't remember. I was in the trials when I was at Henry Ford. But then there was once those trials were completed and about 300 patients were implanted around the country, it took almost 3 years for the FDA to finally approve it. Now it's just come out literally within the last year. When it got approved, it was going to initially be limited to centers that had experience, that were level 4 centers, and level 4 means the highest level of complexity of cases by the National Epilepsy Centers. So it has to be a level 4 center that had previous experience with NeuroPace, which it means it had to be a center that was involved in the trial in some form or another. What's now happening is NeuroPace is going to other level 4 centers throughout the country and getting an overview of that program and saying, do you have all the pieces in place that we're going to also start doing NeuroPace at your center? So since it's been approved, for example, at Spectrum, I was lucky to have the surgeon who did all the implants in Michigan join us on the west side of the state. So we've done 3 thus far and have 4 or 5 that are lined up. Remember, though, this is not something that just is for anybody who has epilepsy. It has very specific criteria. So if you have partial epilepsy, seizures coming from one part of the brain, or in some cases, seizures coming from 2 sides, you may be a candidate. What do I mean by that? Well, in the old days, when we evaluated people for epilepsy surgery, if we found all their seizures coming from one temporal lobe and all the data looked really good, they were a good candidate for epilepsy surgery. Well, what about the patient who ended up having seizures coming from both temporal lobes? You can't remove both temporal lobes, you'll have no working memory left. So one of the populations that NeuroPace can potentially treat are these patients, because you can put one electrode here, and then it attaches this computer stimulator that's implanted in the skull. The other population is a population where you found where the seizures are coming from, but if you remove that part of the brain, you potentially could create a new problem, like a problem with language, a significant impairment in memory, loss of vision, weakness. So most patients who are being considered candidates for NeuroPace are those who have already done a lot of the pre-surgical testing, including what we call phase 2, where you've actually put electrodes in the brain with wires coming out of the head to record their seizures and do brain mapping. Because through that technology and evaluation, you've identified not only where you think seizures are starting from, but can you or can you not remove that piece of the brain with or without significant fallout. So I just wanted to give clarification as those both came up for discussion in the previous talk, just to be sure you understand the big perspective, that that's not something you just raise your hand and say, oh, count me in, schedule me next week kind of thing. So now let's see if we have questions. Yes?
My question is for basically everybody that have side effects. Okay, the medications that I take in the morning, no matter if I eat, take them the right way, or anything in the morning, I still have the type of side effects in the morning. I go to sleep and basically can't function until about after 12 o'clock. It's like every appointment I have, it has to be after 11 or 12, even though I might take my medicine or do take my medicine at 7:30 in the morning. Now, what I wanted to know is, Could it be my size? Like they were saying, like for smaller people or whatever, that the medicine, you know, when you take it, it has the side effects where it makes you feel high, it makes you feel sleepy.
Well, I think that's what you're bringing up regarding side effects of medications is something that we consider and struggle with all of our patients. There's no such thing as a perfect medicine. Every medicine has the side effects. Sometimes those side effects are more severe in this person compared to that person. Our goal when it comes to anti-seizure medication is to provide the lowest effective dose without intolerable side effects. And sometimes we try a medicine and it just doesn't work, and that medicine has failed us. So then we try another medicine, and that medicine doesn't work. And we get in this situation where it's just really hard to find that balance between seizure control and side effects. That's one reason why so many new drugs are coming out, and we're learning about more. Because, again, no drug is perfect, but we have to find the perfect match for that person. I'm not sure if that's completely answering your question, because ultimately we've got to really try and find what works for you.
7:30 in the morning, 7:30 at night. Eat a nice breakfast, eat a decent lunch, make sure I have a decent dinner before I take it. But still, that's the reason why my doctor told me, especially at nighttime, when I take my evening pills, make sure I take them right before I am ready to go to sleep, because I'm gone.
Yeah, you know, unfortunately, you're very sensitive. Well, maybe not very sensitive. Maybe the amount that you're on, I can't comment on that. But some patients are very sensitive to seizure medicine. Remember, our bodies are made not to have foreign chemicals in them. Seizure medicines are foreign chemicals. They work by suppressing or quieting down the brain. So it's like putting a blanket on your brain to keep it quiet. So you can imagine some people, even just on one drug, don't tolerate it very well. And you're on the same drug as this person. They're tolerating it, you're not. Well, why is it? Are you a wimp? No, I'm not. I'm just kidding. You're not a wimp. Yeah. What I was getting at, I'm not implying you were a wimp, is that if you look at how drugs are metabolized, I can give 200 here and 200 milligrams here, but this person's liver works in third gear. Genetically, they were born with a faster liver than you have, and the liver is one of the main organs that metabolizes the drug. So it's really hard to compare person to person. The bottom line is these are drugs that are meant to quiet the brain down. We would love it to just go to the one part of the brain where your seizures are coming from. Unfortunately, it's the whole brain. And as we add more medication and more drugs, it's like you're carrying around a big backpack with weights in it, and it gets heavier and heavier to the point that you just can't tolerate it. And you're in a tough situation, and it's a matter of continuing to experiment and saying, we need to find the drug that works, that gives you quality of life, and kind of move on from there.
Surgery. I was in that study to get the surgery, but like I said, I have them on both sides. And the doctor said if I was to do that, you may end up blind. So either keep the seizures and see, take the surgery, or blind.
Yeah. Thank you.
I have a question on the mood swings that they talked about the last section. Can you touch a little bit on that, like what might be the cause and effect of that regarding the medication?
Oh, man. That's a great question. What's causing the mood swings? Well, seizure medications affect the brain. That's what they do. You know, I think one of the major culprits that we see on the pediatric side for all of this is when we start a medicine, particularly with the young kids. Sometimes that medicine might result in those mood swings, and it is not the same kid. It is a different kid, and the parents come up to us within 2 or 3 days and say, what did you do to my kid? And it's because of these mood swings. Their behavior is just altered and changed. And, you know, and that can be, well, it's frustrating for one thing, but it can be even more so. Why is that happening? I don't know.
I've been seizure-free for 18 years. Okay, taking the Tegretol and the Neurontin. But I've noticed, and the families notice, and they think it's, you know, like James Francis, don't yell at me. Well, I'm not yelling at you. I mean, like, why is that there as opposed to there? I mean, just like that, it seems like I snap something. I don't always catch this. But friends do, family do, and I don't see it. I don't think of it as a big deal. However, it's apparently doing something.
I bet they're wrong. They're just not seeing it. I mean, they're wrong. You got to remember that when we figure out how drugs work, they're first tested in mice, you know, and we say, wow, they work on sodium channels, and how much of that data actually transmits to humans? In many cases, it does. But remember, your brain is this complex network with emotions and connections, and how drug A is going to affect your brain versus that person is quite different. A classic example is levetiracetam or Keppra. Great drug, we've used tons of it, yet there's this 5 to 10% who really get moody with that drug. I mean, we've called it Keppra age. And they have to come off that medication. Well, why them? Is it their baseline circuitry? Is it, we know there's a special receptor for Keppra, but we really don't know what that receptor does in the brain. So you've got a valid concern, and mood swings are not an uncommon problem in this class of drugs. And that's why, again, this trial and error, I mean, I'm sure your probably family maybe is a little accurate, and that might be a reason you have to go to another drug if that becomes an intolerable issue.
This is a question that probably relates to everyone who lives in the United States. Anyway, there have been quite a bit of news reports recently on 60 Minutes, on PBS, cover story of Time magazine last year, essentially all saying the same thing, that we in this country pay the highest price for pharmaceuticals than virtually any other country in the world, and pretty much at the Congress is pretty much at the whim of what the pharmaceutical industry has forced by way of their lobbyists. Much greater prices here, and then I think it was 60 Minutes that says something was written in the Affordable Care Act that Medicare cannot even legally negotiate for the lowest price. And one of you guys would comment.
This is yours.
Okay. You have a valid concern. The price tag here in the United States is quite high, not only with medications, but across the board. And we know that we're in a healthcare system that can't continue in its present form. And a portion of that is trying to control pharmaceutical cost. On the other hand, and I'm not defending or whatever either way, the drugs that are available, the way our system works and the number of clinical trials and the cost of the research to get those drugs passed through the FDA is unbelievably high. And you think about it, if you're starting a business, your budget's got to work. And I'm not saying that there haven't been mis-budgeting issues with pharmaceutical companies just like anything else, but we all do agree that we need to have a new format where we have drugs that are more available across the board. Right now, there's these major changes in healthcare of risk bearing. Who takes the risk? Who pays for what? We're used to this entitlement for years where we got our insurance and it paid for everything. We had no idea if it was $40,000, $45,000. That ain't gonna work anymore. We all have had to take on some additional costs in our deductibles and our premiums. We have to try to design a network where we can provide care to everyone, it's affordable, and we can make people better. So that's a great theoretical talk I just gave you, but how that's going to happen, who knows? There is pressure on pharmaceutical companies, though, and they have changed their ways to a certain extent to make it more affordable. We still have a long way to go. Remember, the government, for example, says, well, there's an easy way to save a lot of money. Let's go generic. Well, we all know what happened in the epilepsy world with that. So, yes, we need to be more cost efficient, but we also have to look after what we're doing and how we're doing it. And I'm sure that's not even close to an answer to your question, but I had to give some response because he didn't.
Yes. How much does the epilepsy affect your memory?
Some of that depends on the type of epilepsy that that the individual has. There are children with absence epilepsy where they're having multiple seizures a day that last for about 10 seconds at a time, 10, 15 seconds. And they're sitting there in school missing their lessons because they're having these 10-second seizures. And so that memory is also, there's a learning effect on that. There are other people that might have temporal lobe epilepsy, where their memory function is impaired because the temporal lobes are a big part of our memory in our brains. And if that temporal lobe isn't working the right way, our memory might not be as good as somebody without epilepsy. And then there are individuals with, if I were to talk about for children again, children with generalized epilepsy, generalized tonic-clonic seizures, they're having these big seizures. We do know that in addition to memory, there can be some, continue to be learning disabilities and behavioral changes unrelated to medicine, but somehow related to their epilepsy. And although we know about that correlation, we don't really know exactly why that is yet. That's something that, as we continue to research and get this evaluated, we will eventually find that answer, but right now we're still trying to learn about that.
Yeah, one of the reasons we want to be sure to control seizures as well as we can, if you look at people who have epilepsy over their lifetime, especially temporal lobe epilepsy, their temporal lobes actually can get smaller or they get scarred because with all these recurrent seizures, there are actually brain cells dropping out. And when brain cells are dropping out, they're from your memory circuits and you're not, especially short-term memory is going to go downhill. So if you've got someone who I see in the clinic and they say, my memory is kind of, well, one of the things we might do is kind of a baseline, what's called Neuro Psych battery, where we actually get the measure of how their memory function is now. Because 3 years later, and they say, well, my memory's clearly worse. Are they being too hypervigilant or critical of their own performance, or do they actually have a significant change because of the continued seizures or side effects from medication?
Well, that's kind of somewhat the answer I got from my doctor, because I told him, I said, Doctor, I'm losing my memories, and I was wondering what's the worst part of it, of my problem affects it. I'm 79 years old. I have a brain tumor. I have epilepsy. What affects it the most? And he said, all of them. Well,
I agree with that answer.
I could have gave you that diagnosis. Thank you.
Yeah, that's a tough answer with lots of risk factors.
How you doing?
Good, how are you?
Brian, I really wanted to direct this towards you. You talked about neuropace, and my son has partial complex seizures, and we're going to Boston. We've been going to Boston to get some opinions about surgery. And I have a lot of concerns with the surgery because you hit it on the head. The surgery may affect other issues, other aspects of his life and that. And I wondered if maybe this isn't a good time to talk about this. Maybe you and I need to have an email dialogue or something like that. But I wanted to know what your more detailed thoughts are. If he's not a candidate for surgery because they are coming from multiple areas, how well does NeuroPace work? I guess I just want a little more information and a little bit more opinion from you about if he is not a candidate for surgery, and we're going to determine that fairly soon. How well do you think NeuroPace could help him?
Sure.
And
Sure. Unfortunately, you know, when there are some patients who, sounds like your son, are multifocal, which means they have seizures not only coming from one area or two areas, from 4 areas. The problem right now from a NeuroPace standpoint is with the amount of electrodes we can implant and can be recorded through the device, it's really limited to 2 areas. So the independent bitemporal are appropriate candidates. Right now, until the FDA approves larger arrays of electrodes to implant, it's going to be limited to that.
Think they're coming from, I'm sorry. Most of the doctors and professionals think they're coming from possibly 2 areas. And they're actually encouraged that maybe they're coming from one and they're actually just, you know, starting locally and then spreading across and that. But even if they were coming from 3 or 4 areas, wouldn't NeuroPace with 2, couldn't you kind of narrow down like 2 of the most dramatic areas that would make, I mean, is that something that you would consider doing?
Well, theoretically, yes. But you got to remember, the brain is always a changing organ. So, for example, when we do epilepsy surgery, we record someone and like almost all their seizures are coming from one temporal lobe, and they only had a couple coming from the other side. We remove that temporal lobe, and they may go seizure-free and never have another seizure. They may continue to only have that 1 or 2 from the other side. On the other hand, they actually could have a spontaneous increase on that other side because the circuitry is all related. And even though this very active site is a problem, it also sends waves that can inhibit some other areas. So you can identify one area and you treat it and it seems to respond appropriately, but we've also, in a sense, potentially could help promote some other sites. And remember, NeuroPace is still early in its use, and how much data we have is still quite limited. So you're correct. It may very well help, but you shouldn't have anybody giving you that guarantee either because we have limited information and every brain's different. Okay. Over there.
Dr. Smith, could you describe the Visual ACE and NeuroPace pre-surgical workup, what that includes?
So the pre-surgical workup for NeuroPace is quite extensive. I mean, for NeuroPace, because you're going to be implanting electrodes permanently in the brain, and they have to be as close as possible to the site, there's a number of studies. You know, the evaluation in the clinic, prolonged EEG in the epilepsy monitoring unit to capture seizures. A lot of times PET, which is a study to look at glucose metabolism in the brain. SPECT, which is an injection of an isotope during seizures. MEG, which is a new machine that records data that the EEG can't see. Most people who go to NeuroPace, though, have to have not only recorded seizures with scalp electrodes, but recorded seizures with the electrodes in the brain and the wires coming out of the head. So it's by far the most extensive pre-surgical evaluation, but it has a purpose. I mean, that team that's evaluating you or your family member, they're like the detectives, and they use all these tests to try to find the problem, because each test has its limitations. And when you're going in there to talk about doing brain surgery, not only putting electrodes in, but then implanting the stimulator, you need to have as much accurate data as you can get before you go down that last final step. Visual ACE is much different. You do have some of that testing, but they typically don't go to phase 2 where you're putting electrodes in, because the whole purpose of Visual ACE is you're trying to get less invasive and you have a clear-cut, deep-seated lesion that you can target. And somehow or another, all the testing that was done said, yes, we think the seizures are coming from that deeper-seated lesion, and that's why we're going with this approach.
I have adult onset epilepsy. I had an aneurysm, and 18 years later, I'm wonderful now. I'm on my 9th medication for seizures, my 3rd medication for depression. I have both non-epileptic and epileptic seizures. I need to know, when do I stop wanting medicine? When do I stop trying medicine? When do I start trying to work it out? I don't even know the difference half the time. One day I'm in the emergency room and, well, you had a seizure, but it wasn't epileptic. And one day I'm 3 days away from somewhere, oh, you just fell out and you're okay now. You know, I don't know. And I have had Keppler rage. I have had depression. I have had, I mean, serious Keppler rage, really. I'm tired.
Unfortunately, that's a tricky situation, to say the least. 9 medicines, both epileptic and non-epileptic convulsions to go with this. That can be very difficult to manage. When we see patients with multiple different types of seizures, and if a patient has had multiple medications, sometimes it's worthwhile to start looking at what other options are there, whether it's a VNS or the diet, ketogenic diet, modified Atkins diet, or if is surgery an option. Sometimes people are candidates for those non-pharmacological agents. Sometimes they are not. Every person is a little bit different. The other situation that you were describing was with both the epileptic and the non-epileptic presentation and the convulsions, the non-epileptic convulsions. Those are tough. And we see a lot of patients that have both of those, both types of convulsions. An epileptic convulsion is related to that abnormal brainwave activity. We see that. Those are those seizures. That's why we're here today. The non-epileptic convulsions can look just like it. Everything looks the same. But the brainwave activity, it's normal. And I can throw all sorts of medicines to try and treat that epileptic convulsion. I can treat with all those different medicines. And my goal is to work on that abnormal brainwave activity. Those medicines are not going to work if that brainwave activity is already normal. And we've got to look at other options. That brainwave, those convulsions, they're real. They're real. You're not faking it. You're not pretending. The problem is that it's normal brainwave activity in that case. And the best thing we can do for that is try and find, not on the seizure arm of everything, but we need to look on that other arm. And the majority of people who have a non-epileptic convulsion, we start looking at counseling and therapy, cognitive behavioral therapy. Those are all very important treatments for non-epileptic convulsions. Once we get those under control, and it's very possible, then for people who have both, then we can start really investigating those epileptic, the abnormal brainwave activity as well. But it's so important that we work it's a team approach. It's a team approach, and we've got to work on both arms in those situations.
Did you say which one first? Well, you really got it. You can't take one or the other. You have a mixed seizure disorder. We have to address them both. It's a very challenging problem because it's not an easy answer. Every time one ends up in the emergency department, short of hooking you up to an EEG when the seizure is occurring, it's a real challenge. So I completely agreed. You have probably the most challenging case out there because it's one thing to have refractory epilepsy and you know it's here, but when you have both sides, it's a significant challenge. And the non-epileptic research and treatment, that's way behind the times. We're finally moving ahead. Patty, who gave your last talk, is on a task force with me, and we're working on some stuff that, wow, this has just been an untouched area, yet it's such a common problem, and it shows up at the epilepsy foundations all across the country. So we're really trying to turn up the gas and figuring out why these problems exist and what are the best ways to treat them. But unfortunately, we're not on course for that right now. It's taken a lot longer because it's always been pushed back to the wayside. Yeah, I think we should take that offline. I'll be glad to talk to you right after this to give you my thoughts, because we could have this conversation for a half hour. But I will be glad to talk with you right after.
I was just going to back up. He had asked the question about the memory, because I'm the same way. My memory, it's getting worse and worse every day. I've been seizure-free for, 6 months. Now I've had a couple breakthroughs, and it is getting worse and worse. It's getting to the point that I don't remember people's names or faces. I had 2 neuropsychs done. My second one was worse than the first, and the second one said, watch for dementia. That scared me. And then I asked him why, and he said it's because of lack of oxygen while you're having the seizures.
Yeah,
Dr.
unfortunately,
Burdett.
some of the fallout from seizures, obviously the harder, longer seizures carry higher risk. And I know when we talked earlier, you've had a hard, bad seizure. And unfortunately, those tend to have the most insult to brain cells. I mean, and I'm not implying you miss medication, but one of the things we want to be sure that all of you who are on seizure medicines don't miss your medicines, because some of the worst and longest seizures end up because of missed medicine, and you end up in the emergency room. And once you lose brain cells, they don't grow back.
I actually have 2 questions. I also have an adult son with epilepsy who has Keppra rage horribly. Why, if they know this is a problem, when they put someone on Keppra, why they don't put on some kind of an antidepressant with it?
It's a great question. Why don't they start an antidepressant with the Keppra? Well, about 5 to 10% of patients who get started on Keppra present with these behavioral changes, this rage. So that means 90 to 95% do not. And I can spin it either way for you. And then there are a good number of those patients who do present with those behavioral changes that improve over the course of 2, 3, 4 weeks. Those behavioral changes get better. If we were to put every single patient on a behavioral modifying drug, I'm not sure how many of them would truly need it. I'm not sure how many of them would truly respond to it. If it is a situation where the patient is having this presentation and does need medicine, it's definitely worth looking into trying medicine and seeing if it works. But just like seizure medications, mood stabilizers, behavior modifications, it's sometimes a trial and error to see which one is really going to make the difference as we go forward.
Yeah, and got to be a little careful. I mean, first of all, if we're talking about using Keppra, if I have a patient with a baseline depression, I might not go down that road. There's been some argument that a little supplementation with part of the B vitamin complex can help, although I haven't been overly impressed by that. The other thing is, you get put on drug A causes a side effect, you say, let's put on an antidepressant, drug B. Guess what? Drug B works for drug A's problem, but now drug B is causing a side effect, so we add drug C. It gets to be a real problem. Remember, these are foreign chemicals in the body. We want to limit the number as much as possible, and if there are 25 other drugs, then maybe it's time to talk about looking at another option that hopefully gives control without that side effect profile.
Hi, I have 2 daughters with absence seizures, and they both have autism as well. And I was just talking about, one of my daughters was just diagnosed with like Javon syndrome, the photosensitive epilepsy. And she also has like some mood issues. So she sees a psychiatrist and a neurologist. Now, my question is, number 1, what happens when they don't agree? And number 2, you know, she takes like she also has thyroid issues, so she takes like Synthroid and she takes Adderall. What happens whatever seizure med she tries, when you go on the higher dose, it doesn't matter if it's like Lamictal, Keppra, Depakote. When you go like on a higher dose, she has learning problems. Her ADD gets worse. So I wanted to know your opinion of trying like 2 low dose seizure meds instead of 1 high dose one. I'm just curious, but I really want to know what you do when 2 doctors disagree.
Yeah, unfortunately, doctors don't always agree with each other.
What do you mean?
What?
Yeah.
It gets frustrating. That's frustrating for the families when that happens. The neurologist might not be comfortable with the developmental or the behavioral management, and the behavioral specialist or the psychiatrist won't be comfortable managing the neurology portion of it. This happens frequently, and we see this happen. We see kids and their parents come in with these concerns quite a bit. Short of putting those 2 doctors head to head, probably wouldn't recommend doing that to you. But you have to do what's best for your child, and sometimes that means a long conversation with your physician. Sometimes that means phone calls and letters to try and figure out, with the notes and everything else. But you need to do what's best for your child. Your other concern was with the learning and learning disabilities. Mm-hmm. You had a child with absence epilepsy, and then Jeavon syndrome, correct? Okay. So there is some. We're learning more about these conditions, and a lot of kids with absence epilepsy have learning disabilities in addition to their epilepsy. And again, it's this correlation that we see. I don't know if the epilepsy is not necessarily causing the learning disabilities. The learning disabilities are not necessarily causing the seizures, but they just happen to be together there. And that gets difficult as well. When children present with this, we recommend, I generally recommend making sure that there's an IEP available. I'm sure she's got one. Yeah. Working on that one-on-one learning. We want to maximize her learning potential when this happens. And we want to minimize the epilepsy. We want to minimize the side effects that go on with it. 2 low-dose medicines might not actually work. Okay. Because if we think about, if you remember, there was a slide, and I really liked the slide. It was about the long-acting versus the short-acting, but you saw the hash lines above and below. It was about the therapeutic level. Right. And if you have 2 low-dose medicines, they might both be underneath that therapeutic level, and then you're really not getting any effect. And so it's monotherapy is usually what we go for, 1 medicine, because we're talking again about, to use Dr. Smith's words here, chemicals in the body, chemicals affecting the brain. We want to make sure that we are using the lowest effective dose without intolerable side effects.
But my daughter also has like the short-term memory issues, like her working with, when she had her 3-year Met reeval, like her working memory was like 12th or 15th percentile. Mm-hmm. So, and she had seizures when she was younger, then she outgrew them, so she was off meds, and then they came back last year when she started going through puberty. So it's just like with all her issues, you just don't know. Well, thanks for answering that.
I have a couple questions for you as well. Oh, only one? My question would be then about you were talking about the non-epileptic seizure versus the epileptic seizure. And I can understand the differences, the brainwave activity. As a parent of children, I have an older son who at age 5 had his first seizure. which was a reaction to the sight of blood. I had the same thing at age 3 and continued through puberty and into adulthood has gotten much better. I have very, very few of them these days, not even one a year. But for a while during puberty, like you said, I had one every other week. So how do you know as a parent, and without having, because they tend to be more reactive, if it's epilepsy, if it's vasovagal response, if it's, the doctor said, well, it looks like epilepsy, it acts like it, but it's not. Now, this was many years ago. So then, now I have a son that is doing the same thing. His younger brother is diagnosed with epilepsy at Spectrum this year. And so what about the genetic or the familial traits being passed down that way? And how do you know the difference? And how, because they don't happen all the time, how can you find out or advocate for your children who are having obvious seizures, a tonic-clonic looking seizure, whether or not they fall into the epilepsy group or just get pushed aside? Like you said, that research has been pushed aside a lot.
Well, yeah, that's a great question. How do we know if it's a seizure or if it's a non-epileptic convulsion here? If we can't figure it out, if they look the same, they smell the same, they're doing the same thing, sometimes the situation in that case is to actually admit the child into the hospital and do long-term video EEG monitoring until we capture an event, and then we can try and characterize what's happening to see whether or not that abnormal electrical activity is occurring or if it's normal. Easier said than done, right? I mean, sometimes we get it, sometimes we don't. In those situations, if we never capture the event, so we got to keep trying. We got to keep trying and get those answers. There are, in situations, ambulatory EEG could be considered. Outpatient, long 4 to 6 hour monitoring might be an option as well. Every patient's a little bit different in how they on how they present. It's not uncommon for children or individuals with family members who have epilepsy to have similar presentation without it being a seizure, to have a non-epileptic spell, a non-epileptic convulsion that looks like their family members, their loved ones' epileptic seizure. That's not unheard of. We see that a lot. The way we know about that, the way we figure it out, is to try and capture one of these spells, one of these convulsions on long-term EEG monitoring.
The big thing, in my opinion, is is there some way that we can warn the individual of a coming seizure that's about to occur? So you got your smart dogs, that's great. It'd be nice if there was some kind of device that could be maybe attached to the head somewhere that would warn an individual so that they could get in a safety position prior to the actual seizure. Is there any kind of vision for that? Has research given any consideration to that so that the individual can actually be positioned safely and then not have any of the problems that could come from an untimely seizure?
Yeah, it's a great question, and there's been tons of research in that direction, because that would be the magic bullet. If you could identify a program or something that gives you that warning, where you could go lie down, or you could get in a comfortable place, or you could turn off the car, or whatever. You can imagine what a difference that would make. So if you go back 20 years now, there's been research looking at that. The problem is that that's not an easy task. I mean, even if we just look at you coming into an epilepsy monitoring unit where we've got electrodes all over your head, and we should be able to detect when a seizure is starting. Well, by the time the activity reaches out here, it may already be too late. And so there's lots of work going there, but it's not an easy task. The brain is very complex, and there's so much other activity and artifact that makes that very difficult. So everybody agrees with you, and there are lots of people still working on it. We're just not there yet. I know Patty showed a detection slide because that's what people want to do. They want to detect and get to safe place. We're just not there yet.
When you have a child that is got multiple issues, my son has multiple medical type issues. He has cerebral palsy and autism and genetic changes and things like that. He is diagnosed with a 16p deletion syndrome, which in part they're using to explain the epilepsy. How do we know, as a parent, as a caregiver, which thing to attribute to which condition? In Rowan's case, he has global delays and things like that. And a lot of it, the epilepsy medication seems to worsen. Like recently we had to drop his Zorotin because his body wasn't processing it right, and when we tested him, even though the numbers matched up, it was not being processed by his system very well, so it sent nasty notes to the doctor and said, hey, lower this. How do we know which things we can attribute to the epilepsy itself? Does that make sense?
I think I understand what you're saying. So how do you know if the symptoms are related to the underlying epilepsy or if they're related to medicine or something environmental? Well, the easy answer to say is if you take that outside influence away, do those symptoms go away? Sometimes we can do that, sometimes we can't. We can try and lower the seizure medications and see if that see if that causes the symptoms of perhaps learning difficulties, word finding difficulties is something that we might see. Do those improve as the medicine is decreased? At the same token, I don't want your child to have a seizure because I'm dropping the medicine. So it's a fine balance when that happens. I've got to make sure that I keep your child safe. I got to make sure that your child succeeds and learns at school and maximizes that learning potential as well. So as we try and play around with some of those environmental changes, what happens? And if those symptoms don't change and we've eliminated that possible environmental effect, that environmental variable, like a particular medicine, well, then it probably was not the medicine that was related to it. And then we have to, okay, are we back at square one? No. We've crossed this piece off the list, but there are other pieces that are still on there. And we have to do it at a step-by-step basis. If we take everything off the list all at once, which one was the cause? We got to do it one at a time, and that takes patience, and that's hard. Patience is hard.
Not very good.
I'm coming.
Hi, I've been involved in the healthcare field for 27 years, mainly on the behavioral health care side around treating addictive disorders and mood disorders. And my son has a seizure disorder, epilepsy. And my question to you is, I really appreciate the advances that have been made in neurology and psychiatry around brain science and a better understanding of what's going on. But where I'm really looking for direction is around how to best coordinate care. I am incredibly frustrated, and I'm in the healthcare system. And I know as a federally qualified health center, we're trying to help people better coordinate care. And as part of what's broken is the coordination of care and not just the cost of pharmaceuticals. But where does the advocacy for the coordination of care lie when I've got a psychiatrist and a good neurologist or a neurologist involved and a primary care physician. And the primary care physician and I are more on the same page of trying to get him in to the limited number of psychiatrists that are available, and he can't get in for 5 months to have his anxiety disorder and his depression disorder looked at to see the interaction between his anti-anxiety drugs, his mood stabilizer around depression, and the Keppra and the Dilantin he's on. So I know there's no silver bullet, so I'm not asking you for the silver bullet. But where does patient advocacy lie, not just as a parent, but within the healthcare systems of both primary care and the specialist care to get the psychiatrist and the neurologist to talk to each other? I don't even care if they disagree. I want them to talk to each other.
Yeah, it's a great point. I completely agree with you. There is this disconnect, and you got to remember, you've had all these physicians in their practices, and they kind of do their thing, and they feel they're doing it right, and whether they talk to the other guy doesn't seem to make any difference. Well, guess what? It does, because there's so much overlap. And so I was just finishing, we just opened a new complex on the west side of the state called an integrated care campus. And part of it is based on that whole concept, because remember, healthcare transformation means going from volume, how many patients you see or how many procedures you do, to quality. And how do you do that? Well, the first step is communication and a seamless organizational structure where that happens. What you'll really like is that as healthcare changes, that risk-bearing of who's paying the bill or who's getting reimbursed is changing. So you've heard of patient-centered medical home. Well, starting in February, for example, for a neurologist, there's a program called Patient-Centered Medical Home Neighborhood, and they're going to be measured, it's called population health, where this number of patients who fall through this physician organization through the primary care, they're going to be looking at that kind of data. And a big reflection of that score is the communication between the specialist and the primary care physician. I'm not saying it's the perfect answer, but it's the beginning of a process that is very, very problematic, just as you stated, and needs to be fixed. Because think about it, you're not getting the communication, you're seeing the primary care who ordered this blood work, see the neurologist 2 weeks later in a different system, and he repeats the blood work. Look at the cost, look at the pain to the arm, and look at the lack of communication. And there's lots of examples. So you've got a great point, and there needs to be movement.
All right, and I appreciate your answer, and I agree with that. I'm just saying in the meantime, I've written letters to both the neurologist and the psychiatrist and saying, guys, get together, talk to each other, please. Here's what's going on. I've heard back from neither of them. Not that they can get back to me because of HIPAA. I don't have a release from my son to talk to me. I understand that. I just want them to pick up the phone or their email or whatever way they can communicate with each other and do it. So if I called up your well-recognized and reputable clinic at Spectrum Health around epilepsy disorders, would they assume the patient advocacy role to make sure that these connections occur between my psychiatrist or my son's psychiatrist and my primary care doc for my son? Is that something your office would do? I just wonder where it is.
No, they're not 100% by any means. I'm sure I can go to my clinic next week and find gaps just like you're talking about. So it's a work in progress, not only where I'm at, but I'm sure across the metropolitan area and the state. So you've got valid concerns. You just got to keep pushing the envelope, because if you don't, things don't change. We've got 5 more minutes, I'm told.
Quick question. My brother has TS. He's been on multiple meds, and okay, can you hear me? And he has uncontrollable seizures. As a family, recently we decided that we were going to take the medical marijuana route, and we've had some success, and it looks hopeful. The challenge, or the question that I have for you, we have a resource here on this side of the state for CBD oil, the more similar to the Charlotte's Web, very little THC. I was just wondering, on your side of the state, do you have any patients that would share or their resources or their experiences with the Charlotte's Web or the CBD oil?
Oh, I can tell you, just last week I had a couple patients who feel they've benefited from that. Unfortunately, I don't have a good place on the west side to get it. They've gone to Ann Arbor to actually get the CBD. But a little caution there. I know there's a lot of excitement and a lot of press on that, but as you well know, there's really no scientific data. You know, it could be like me going into my garage and taking some old Frosted Flakes Cheerios, smashing them up, making a pill, and saying this works, and 20% of my patients will respond. You know, there's that placebo effect. The studies haven't been done, but I can tell you I've had enough patients that I think there's been a positive response that I'll sign the form and I'll give them that information and let them try. Yeah, I only, and moms are the ones who are giving me this information. I only know of Ann Arbor and a Lansing site right now that have that available. There could be more, but I can tell you that what the moms told me, there was a big price difference between the site in Ann Arbor and the site in Lansing. That's why I'm sending them to the one in Ann Arbor.
I found that the dispensaries in Ann Arbor, with the testing is not, with the iron lab, the potency isn't there. And the same thing with the Lansing with the area. So I was just wondering if there's somebody on your side, but evidently there isn't, because the ones, just a word of caution, because the ones in Ann Arbor and Lansing don't have the potency.
Well, and I can connect with you, that mom, after this talk. Yeah. Apparently we have 47 seconds left.
Yes. My son had, his seizures were in control up until he's about 24 years old. We went to U of M. They did the video monitoring and all that. He was not a candidate for surgery. They did the VNS therapy. It's been almost 2 years. They said at 2 years, that is the peak. That's where they could probably start, you know, working the best. It has not worked at all. They keep adding meds. They said by now they should be able to reduce. What do you feel on the V? I feel I made a big mistake because now he can't have an MRI from here up. He can't, if there was a heart attack, they can't do AED. What is your feeling on the VNS?
VNS, there's evidence that it works. I think that the VNS is a very effective form of treatment for patients who have not responded to medical management, where the medicines have failed the patient. The VNS is an option, and it's a viable option out there. Unfortunately, there are situations like your son where after several years on VNS, it hasn't shown improvement. There are rapid cycling, there's adjustments that you can make on the VNS, but even once all that is maxed out, you know, it's unfortunate when those situations happen. That doesn't mean that we give up. We keep working. We don't leave you hanging out to dry. We keep working with you and find out what other options are out there to try and help the patients, because they're the most important people in our clinics when we are in there.
The numbers that I state is about a third of patients will benefit, that they'll have a significant seizure reduction. Very few, if any, will ever become seizure-free just from VNS. So as long as you were under that kind of perspective, that would have been valid, yeah, to move ahead then. It's just unfortunate. That means 2/3 are not going to have a significant benefit from it.
Well, unfortunately, our time is up. We want to thank Dr. Smith and Dr. DeVries for being with us today. We really appreciate it.